it has become very difficult to make long-term decisions. Fortunately, we can't look at overall survival very easily anymore because the median survival of myeloma patients has gotten to be so long that the field moves too quickly to use those overall survival endpoints, particularly for therapies that are being applied early in disease. So what can become the surrogates? Well, the one that is spoken about the most is how many patients achieve minimal residual disease negativity. And that's going to be an important endpoint. But that doesn't translate into long-term survival for all patients. There are patients with very high-risk disease who, despite achieving MRD negativity, unfortunately relapse and will succumb to the disease relatively quickly. So are there other endpoints? Well, one of them is relapse from MRD negativity. So not the percentage of patients that achieve MRD negativity, but how fast do they become MRD positive after that? That shortens the endpoints, makes it easier to look at some level. But I think the molecular characterization of the patients, the identification of patients that have acquired proliferative appearances of their disease, proliferative phenotypes, that what turns myeloma into a fatal disease at the end is that it starts to grow more quickly. And that seems like, well, of course. But myeloma, for most of its course, is a disease of accumulation. It isn't a disease of rapid growth, and it is the evolution to rapid growth on top of immortality of the cells that makes it dangerous. So when we learn to identify that subset of patients, we're going to use that to judge the efficacy of things that we do. If we do something that increases the number of patients that look like that at the end, it's going to be looked at much less favorably than something that doesn't increase the number of patients who look like that. So I think once we understand that, we're going to be able to make decisions much more quickly about what therapies are the best therapies and what therapies aren't.